Welcome to today's webinar, the 6th Renal Nutrition Ask the Expert webinar, hosted by Vitaflo. Today's webinar is titled Anthropometry and Assessment Applications in Pediatric Kidney Disease. A few housekeeping items before we get started. The webinar will last approximately 60 minutes and will include time for questions at the end. If you would like to ask a question, please use the question feature on your GoToWebinar toolbar. All questions will be screened and a select number will be answered by the speaker at the end of the presentation. The webinar is being recorded and will be available on the VIA website in early 2020. You can access a PDF of the presentation slides, a certificate of attendance and a self-reflection tool in the handout section of the toolbar. The views herein are of the presenter and do not necessarily represent Vitaflo's views. The material herein is accurate as of the date presented and is for educational purposes only and not intended as a substitute for medical advice. Vitaflo is delighted to introduce our speaker, Chris Nelms, for today's presentation. Christina is a pediatric renal consultant dietitian, training practitioners in the art of pediatric nutrition care. She also teaches nutrition classes through the University of Nebraska. Christina worked previously at children's hospitals in Omaha, Nebraska, Oklahoma City, Oklahoma, and most notably at Children's Mercy in Kansas City, Missouri as a senior staff member. Whilst there, Christina enjoyed working with a variety of pediatric renal conditions, dialysis patients, and acute care patients, as well as being involved with research and teaching. Chris is the lead author for the renal chapter in the Aspen Pediatric Nutrition Support Core Curriculum and the pediatric chapter in Nutrition and Kidney Disease. Christina is currently finishing a chapter for pediatric dialysis, as well as several journal publications. Chris is a frequent speaker at national and international conferences and is the chair of PRONA, a pediatric renal nutrition practice group, as well as a member of the Pediatric Renal Nutrition Task Force, which is an international group of pediatric renal dietitians and nephrologists creating clinical practice recommendations for worldwide use. Vitaflo would like to thank Christina for taking the time to present for us today. I'm about to hand over to Christina in the USA now. Please be aware it might be a short delay in handing over controls. So over to you, Chris.
Good morning, everyone, or should I say good afternoon? It's morning here in the US, and I understand it's rather late in the day for you. I wanted to thank Catherine for that kind introduction and thank everybody for attending today. Excuse me. As I mentioned, early in the morning here, so if I'm a little froggy from time to time, that's my excuse. While we're waiting for the delay in slides, I believe you have the handouts and can just follow along. So I'm just going to jump into the objectives that we have for today. We're going to talk about the reasons anthropometry and assessment is important in pediatric renal nutrition care, guidelines for anthropometric measures, assessment of under and over nutrition, and the tools that we can use to complement our primary assessment. Again, a little bit of a lag in the slides, but if you have those at home, we're going to talk about reasons to assess, and there's multiple reasons why assessment is important, but I'm going to just talk about some of the biggies. Assessment allows us to adjust things, whether it's a diet or whether we need a nutrition-related medication. Maybe we need to alter the dialysis for nutrition to complement the nutritional profile. We also know that children younger than 3, although nutrition is important at all ages, really the under 3, it's critical. Not only does good nutrition promote growth and can affect final adult height, but it affects neurocognition. So really things like IQ development are at stake with good nutrition and thus how we assess it. Okay, there we're going. There is a greater risk of death. We know from several studies that risk of death is in a U shape according to BMI. So people very overweight or very underweight are at risk of death. And for a long time, it was thought that height was just a cosmetic issue. But now we know that for our patients, for each standard deviation score in height from the norm or the average of either height or height velocity, we face a 14 or 12% respective increased risk of death. And actually, children who are shorter than the first percentile have a twofold risk of death than taller children. We know that appetite is something that we should assess because anything other than a very good appetite is associated with poor quality of life and risk of things like hospitalizations or ER visits. And we know that our patients tend to have abnormal body composition and increased central adiposity, which puts them at risk for more diseases. So we need to know how to assess that and what to do with it. So I'm very briefly going to go over this because I'm going to be talking about these parameters throughout the presentation today. But the KDOQI guidelines, the Pediatric Nutrition KDOQI guidelines, came out at the very beginning of 2009, entitled the 2008 Update. And these, for a long time, have been considered the foundation of how we care for children with kidney disease. And we know that these give us some basic guidance. Children with CKD should be assessed more than or at least twice as often as healthy children. Our sicker kids and our younger kids are the ones that need to be assessed more often. We know that worldwide, because the WHO growth charts reflect a healthy population of non-obese breastfed children, that the WHO growth charts are recommended worldwide, and then local growth charts can be used after that. For example, Dutch children tend to be smaller or taller than many other populations, so perhaps using a local growth chart may be more appropriate. Z or standard deviation scores complement what we do with growth charts, and we need to look at anthropometry in the context of dietary evaluation and biochemical evaluation. And again, I'm going to go into more detail about this. So what I wanted to show you on this slide is this is a table straight from KDOQI looking at parameters for nutritional assessment. And you'll notice here on the left, of all the parameters that we look at, all but 2 are anthropometric measurements. And that's why we are spending so much time on anthropometry today. Just basic, simple growth measurements are what we really care about. Dietary intake is more important, and unfortunately, we don't have much in terms of biochemical measures. I also wanted to point out here, of course, it depends on the parameter that we're looking at, but a child older than age 3 who is only CKD stage 2 may not need their dietary intake assessed as infrequently as every 12 months. But a baby on dialysis is going to need their weight measured maybe as often as weekly. So you can see that difference there. So I wanted to highlight that we do have new guidelines coming. KDOQI is now 11 years old, and it's still a great foundation. A ton of research went into the establishment of the KDOQI guidelines, and they maintain a foundation from all the research up until about 2006 and a little bit beyond. However, this Pediatric Renal Nutrition Task Force is made up of 14 people, 7 dietitians, 7 doctors, pediatric nephrologists, and pediatric renal dietitians, to take the research that has happened since KDOQI guidelines have been published and provide updates topic by topic, where KDOQI looks at everything nutrition related. The PRNT is attempting to update topic by topic, and then hopefully go back to those topics one at a time, and again, update them as needed in the years to come with newer research. And one of the reasons that I'm speaking to you today is I have been heavily involved with the coordination of the assessment guideline. Now, again, the goal is to provide simple, basic instruction with these clinical practice recommendations, especially for parts of the world where there may be not a lot of nutrition support right now. The calcium and phosphorus management guidelines are in press right now. In fact, you can find them on the Pediatric Nephrology website. All publications will be in Pediatric Nephrology as open access documents. Energy and protein needs for children with CKD is also in press. And I will let you know that the assessment guidelines are just ready to go out to Delphi review. They are actually in the process of being prepared for the Delphi review right now. And what that means is that we realize that we can't have every part of the world, every single country represented on our task force. And so we're trying to get worldwide input on these guidelines to make sure they truly represent standard of practice by involving clinicians from around the world. And the first two guidelines that have been printed have had rigorous review from parts of Asia, Africa, all over Europe, etc. So these guidelines will be rigorously reviewed and should hopefully be out to you soon. Because they are not published yet, I thought, and we know that there could potentially be changes from the Delphi review, I thought I would just highlight some themes that I think you'll be seeing with these guidelines, which is that growth is the primary and best measure of nutrition status. Other measures may complement standard growth measures, but we know that growth is best, so we talk about complementary tools. Trending on growth charts where we can really see changes in growth is important, and of course, the regularity of assessment of growth. Now, throughout this webinar, I'm going to be talking about much of the information that we have used in creating these guidelines. So in some ways, you might be getting a bit of a sneak peek. So let's start now with guidelines for anthropometric measures. And this webinar has been created for all levels of clinicians, those who might be starting, those who might have some experience. So bear with me if some information is more basic, but I wanted to make sure that everybody was on the same page. So to start with, we need to consider weight. And unfortunately, in our patient population, a weight is not just a weight. Many of our renal patients may have things that alter our weight. So we need to be considering issues like whether our patients still have urine output or limited urine output, whether they're retaining fluid, edema, or possibly whether they're volume depleted. Some of our patients have issues that cause excessive urine output where they actually can be dehydrated and thus slightly below what would be considered a euvolemic weight. To measure our patients, we need an infant scale that's digital to be used until a child is 2 years of age or able to stand, and then a digital scale, as you can see my picture there, that they can stand on and measures to 1 to 2 decimal points is appropriate thereafter. Now, this also comes from Kadoki, but we have some guidance already on how we want to assess what a dry weight actually is. Now, dry weight is, or euvolemic weight, is the weight at the termination of a dialysis session below which a patient becomes hypotensive. And certainly not all our patients are on dialysis, but it's also the weight that they would be at if they didn't have edema, for example. Now, our patients are complicated that they're still growing. We expect them to be gaining some weight gradually. So it's particularly tricky to determine this in pediatrics. So let's talk about the initial weight and what we do with that. Some of our patients on peritoneal dialysis may have a daytime dwell, some dialysis fluid in their belly. And so we want to subtract that out because typically that will be a known amount to determine what a dry weight might be. We need to be aware of volume depletion, like I mentioned, if we have excess urine output. And if our patient is having rapid weight gains, we need to realize that that's probably not real weight. The presence of edema, and Kadoki says that we should further assess that with a physical exam if it's present. However, we don't have research in PEDS patients because it would really depend on the size of the patient, but we know in adult patients that when you have edema, you already have 3 to 5 kilograms of extra fluid on. So we know that our patients have quite a bit of extra fluid on when we're actually physically seeing edema. So we have to know that the patient is quite a bit over their dry weight. Blood pressure. Now, blood pressure is a big one. It's not the only one, but we know that hypertension that is responsive to dialysis may indicate additional fluid. If we can get that blood pressure lower by dialyzing a patient or by diuresing them with diuretics, that indicates that we had extra fluid on. Biochemical parameters, and certainly there are other reasons that these may be altered, but a high or low serum sodium or albumin may indicate dehydration, where a low serum sodium or albumin may indicate overhydration. Again, there may be other things that influence these labs, but they're one of our pieces of the puzzle that we can look at. And certainly our dietary intake should match what we're seeing with patients. If we're having patients with weight gain that are eating minimally, that's probably not real weight gain. Now, I'm a big believer that the nutrition professionals can and should be involved in the assessment of a euvolemic weight. Often it's left to the nursing staff, but I am a big proponent of four eyes are better than two. I would actually go in at the end of my nurse's time in clinic with the patients, and together we would look at blood pressure records. We would look at the patient. We would ask them questions together. And together as a team, we would really determine what that patient's dry weight was, because it was probably more accurate with a second opinion. So we know that I went to actually some standard patient education websites to see, okay, what are we telling patients? And for example, the National Kidney Foundation tells patients that they should consider their blood pressure, cramping or lightheadedness, swelling, and breathing issues. So here are some examples of questions that these websites ask the families to consider to tell their healthcare professionals if they might have extra fluid on. And I think these are certainly questions as dietitians we can be asking in conjunction with our nurses. Things like, have you been exercising more than normal? Is there any reason your dialysis treatment didn't run as long as it should? Are you dizzy? Are you fainting? These are all things that we can help determine whether a weight is actually a dry weight. I apologize again for the frog in my throat. Let's talk about blood pressure a little bit, because it is one of our best, again, not the only measure of dry weight, but according to KDIGO guidelines, which are the international guidelines, our patients should have blood pressures that are less than the 50th percentile. And I think dietitians should really have a good grasp on what normal blood pressures are for age. And these are in tables by percentile based on the child's gender, age, and actually height. And so I think having handheld copies or a quick link in a handheld device is helpful until you're pretty familiar with what a normal blood pressure is or what we're kind of looking for. And I've included a link there that you can access that. Now, remember, children, well, people in general who are fluid overloaded or underweight, their bodies adapt. So once even we've got a patient down to a dry weight, it might take their blood pressure some extra time to respond. Likewise, a person who's had chronic high blood pressure may adapt, and their blood pressure may actually look normal even when they've got fluid weight on. Their body's adapted to that long-term excess weight. Now, I know I just showed you some American blood pressure charts, and I asked myself, do blood pressures differ in different parts of the world? So I looked up and I found some of these studies looking at Saudi Arabian patients, Iranian patients, and children from the United Arab Emirates. And interestingly, they use the AAP guidelines. So they also noted that the more a patient weighed, the higher their blood pressure was likely related to obesity. One exception to this, there was a very recent 2018 Egyptian study that did calculate blood pressure norms. And there also are Turkish norms for blood pressure, I found through reviewing this article. And they actually had a pretty huge number of patients, over 60,000 healthy children that were used to establish these norms. And you can see the quote on the side that these authors were promoting that there are differences based on environment or ethnicity, and they promoted that there should be standard blood pressure norms and centiles for different parts of the world. And they did note that their 90th percentile was a little bit different than either American or Turkish norms. So I guess my take-home message would be, if you are comfortable with blood pressure norms, if they've been established for your country or region of the world, certainly that may be a little bit more accurate, but so many populations use the AAP norms that it's probably also okay to use that. You'll notice I've also included a link to this article. So the important thing is consistency. If we're looking at trends, we want to use the same normative data one way or the other. So just be comfortable with whatever norms you're using. Okay, so further assessment, like I said, blood pressure isn't the only thing. Remember to look at dietary assessment, biochemical parameters, some things that we're not going to be doing as dietitians, but that we can certainly look at in the chart or ask our nurses about, are results of any lung auscultation or chest x-ray that might indicate fluid in the chest. And touching and looking at our patients, specifically the mouth. Your mouth can be very dry if you're dehydrated. Skin turgor is a good clue of hydration status. We're going to talk about this more later, but remember, we've got lots of pieces of the puzzle to help us in assessment, and they all work together. So now we're going to flip from weight to linear growth. And you can see here that we use a stadiometer, which is on the right, for standing children in older ages, and we use a length board in younger children. Up to age 2, but as old as age 3 is considered appropriate, especially if you have a child who wiggles or can't stand up straight for whatever reason. It's very important that 2 people do this length measurement, one to hold the child's eyes and ears parallel and make sure the chest stays even and upper body stays flat, and one to hold down the lower part of the body to make sure the buttocks and legs are flat, and then taking that heel and pushing it out against the foot piece. This method is pretty much the same for standing. We want them flat against the wall, everything against wall, eyes and ears parallel. We also need to make sure they're not wearing a ponytail or something that would increase their height. So in complement to our standard linear growth measures, and I will mention a length board is absolutely essential. You cannot just do marks on a piece of butcher board in this vulnerable population and expect to get an accurate height or length. So one other tool is looking at height velocity. So we know that children at different ages grow different rates, and there are curves that look at what the 50th percentile or the average rate of growth would be by age. A 6-year-old versus a 12-year-old are going to grow a certain number of centimeters per month or per year differently. And what I've included here, because I'm not aware of anything based on other countries, but this is an American reference. And I have a calculator tool later in my presentation that will have a handy little calculator to calculate the rate of growth. But we care about the rate of growth because if we have a child who earlier in CKD or before diagnosis was growing quite well and suddenly they're not growing well, they might be at the 25th percentile for height, which we would think would be normal. But if they were previously at the 75th percentile a year ago, their height isn't doing as well, and that's a problem. Another important tool that we have is mid-parental height. And this is only available if we have data from both the mom and dad. Optimally, we measure both mom and dad, but sometimes a reported height might have to do. But we basically, for girls, we're going to average the mother's height with the dad's height minus 13 inches. For boys, the father's height averaged with the mother's plus 13 inches. You add the 13 inches or subtract it before we average it. Now, keep in mind that children, even within the same family, may have an 8.5 centimeter deviation. You might have one child end up at a certain height and their brother end up a few centimeters shorter than them. That is just normal within families. But the reason this is important for our patient population and what I wanted to show you here is an example of a child who is not meeting their height potential. You look at this child and they're plotted at the 25th percentile and you might think, oh, well, that's just fine. But if you look at the father's height and the mother's height, average them together, you can see that that child should actually be much taller. What we do is we take the average of the parent's height and plot it at the end of the growth chart, whether that's 18 years, 20 years, wherever the growth chart ends, depending on the growth charts that you're using. And we can see how those curves compare and if our patients are actually reaching their genetic potential. Let's talk about some alternatives to standing height quickly, just in case you happen to have patients who are wheelchair bound or have a medical condition that they're contractured and can't stand straight. So children, we know that recumbent length is used for children who are younger than 2 or 3, as it may be the case. However, recumbent length can still work for children ages 4, 5, 6. We don't want to use that, but if we have a child who's unable to stand, these younger ages, we can still get a pretty good measurement. Now, the difference between length and height is that gravity sort of shrinks you down, an average of about 0.7 centimeters when you're standing. So if we are plotting a child who is 4 or 5, if we're using a length, but we plot them on the growth chart that is using standing heights, we need to realize that that patient is actually about 0.7 centimeters shorter when we plot on the growth chart. If you have a child who's older, because recumbent length doesn't work quite so well as children get older and taller, it's much, much less accurate. Another alternative is arm span. And this is measured, you can see the picture at the top, from the tip of the third finger to the tip of the third finger on the other hand, with the arms stretched wide, flat across the chest. This measurement is highly correlated, but slightly underestimate. So if we're using this, we want to trend it and see that the child is, we want to look at their growth patterns, but know that this might underestimate slightly. To make this more practical and a little easier to do, thus a little less likely for error, we might want to measure from the center of the body out and just double it. If you have a child that's contractured and can't stretch out, this is less accurate. And in that case, an ulna length may work. My colleagues in the UK swear by knee height. I have found from my research, ulna length to be a little bit more accurate. But you basically measure, and I've got a link that will show you this visually later in my presentation, but from the wrist bone to the bottom of the elbow bone, that way we're just doing from one joint to one joint. I've got a couple equations there. This measurement has also been found to be highly accurate, but slightly overestimates. So again, we want to know that it slightly overestimates when we're trending. Growth charts. Let's talk about what growth charts to use. Now, we know that the WHO growth charts are ideal for children under age 2 for all parts of the world. And I've included here the growth charts, or a growth chart from the actual WHO website. However, the CDC, Centers for Disease Control in the US, also has the WHO growth charts on their website. And I like them a little bit more because there's more curves, but I've included links to both sets of growth charts no matter what you want to use. So although these are CDC, they are actually WHO standards. So these can and should be used for all children under 2 and can be used after age 2, depending on your comfort with the growth charts from where you live. Another thing that we might need to consider is that there are growth charts for specific genetic conditions. Now, we don't want to use a growth chart that may be affected by poor care, but we know in conditions such as Down syndrome, Turner syndrome, that these children grow different than healthier children, especially they tend to be shorter. And so we want to compare apples to apples if we're looking at whether a child is growing optimally. So if you have a child with kidney disease that happens to have Down syndrome, these are the growth charts that you want to be using. So which growth charts after age 2? I again wanted to look and see what were appropriate growth charts for the Middle East. So I found this article, and what I found interesting was they did a study of 105 dietitians or pediatricians and found that even though there are Saudi growth charts, over 70% still used the World Health Organization or CDC growth charts. And the reason, according to the study, that that was true was that there were some questions in the development of the Saudi growth charts. And I'm not going to argue that point. But what I did want to highlight from the study is just over half only were using growth charts regularly. And that really is a statistic that should change. Growth charts should be used and plotted at every clinic. The point is, whether you use, if you're in Saudi Arabia, whether you're using Saudi growth charts or CDC growth charts, be consistent. Know what your facility wants, because you're going to have error if you switch back and forth between the growth charts. So whatever growth charts we use, we need to be consistent. Of note, these are the Saudi growth charts, and I wanted to just have a link here so that you can find them if you're interested. Interestingly, they include head circumference even after 2. That's different than CDC and American growth charts. These are growth charts for Egypt, specifically for South Sinai, and I just included a couple growth charts from each of these just as an example. Interestingly, Egyptians were the only ones that had Down syndrome specific growth charts. So, and actually it was based on about half the number of children that the American Down syndrome growth charts were based on. So it's helpful to know what's available in your country. I think you can use US growth charts for some of these rare conditions if you don't have them available where you live, but it's worth looking and making sure that the N value, the number of kids they used, and their methods in developing them were rigorous in deciding to use them. These are a different type of Egyptian growth charts. Interestingly, head circumference only. Some others, and I apologize that I couldn't go through every single country, but you'll see here some examples. There's growth charts for Turkish children, for the United Arab Emirates, for Iran. So lots of different growth charts depending on where you live. Israeli children. Some other information that I found, there are no growth charts for Qatar yet. Qatar, how I apologize, I hear it pronounced different ways. So growth data in Qatar is typically done on CDC or WHO growth charts. A study in Jordan used CDC growth charts as their comparison. So again, it's just knowing what you want to use and being consistent with it. So I wanted to show you this tool, and I've included a link where you can find it. This is an online tool that's very common. This is an American tool, so keep that in mind, but it might give you a place to start, or an online calculator that will actually be helpful. So when we're looking at growth and rate of growth, we need a calculator to calculate standard deviation scores. So I can tell you 0 correlates with the 50th percentile. That is the average of how we want children growing. A -2 z-score correlates with the 1st percentile, and a +2 standard deviation score correlates with the 99th percentile. And I think it's helpful to have a z-score, because if we just say a child is, let's say, less than the 3rd percentile, that could be a -2 standard deviation score, or it could be a -4 standard deviation score. And that's a big difference in height and how well they're growing. A -2 is pretty close to the bottom of those curves, but a -4 is far from it. Okay, lastly, head circumference is a measurement for ages up to 3. Some growth charts only go up to age 2. However, this is a very important measurement for nutrition status as well. And we know that there are reasons that children genetically or may have comorbidities like hydrocephaly that causes a large head, where certain genetic conditions have small heads. For example, a child with Down syndrome, that's why they have different growth charts, is going to have a bit smaller head than children who are healthy. We know that we want to measure just around the largest part of the head using an adjustable tape measure. And although head circumference can be, because of these comorbidities, inadequate head gain in the younger years can indicate malnutrition. Again, I wanted to just include some helpful links. That PD Tools webpage the WHO training course that goes into the specifics of how to do these measurements. And then this is a commercial website, but why I included it is because it shows the ulna length and knee height and some of those alternative measurements in more detail than I could include visually in this presentation. Okay, we're going to move now to assessment of under and over nutrition. So very recently, in early 2019, the International Peritoneal Pediatric Peritoneal Dialysis Network published worldwide growth data. And the take-home message is that underweight and overweight obesity is a problem in all parts of the world. Certainly, and again, we get back to that U-shaped curve, knowing that children who are overweight or underweight are at greater risk of morbidity and mortality. Enteral feeding can be a great tool to prevent underweight, but we also want to avoid excess enteral feeding to prevent obesity later on. So you'll notice in areas of the world such as India and Southeast Asia, Turkey and Central Europe, we have more underweight. In the US and Middle East, we have more risk of overweight and obesity. And that was based on a huge number of children worldwide. So let's talk about how to calculate BMI and or weight for length. You switch over when you start doing a standing height. So it's basically a measurement to assess proportionality. You absolutely have to have an accurate weight or length. This is the calculation how to do it. The unit is kilograms over meters squared. For any Americans who might be listening, we tend to use pounds and inches, and there is a conversion factor of 703 to make this make sense. We plot with weight for length, we plot the weight on the x-axis and the length on the y-axis to determine this measurement. And just to show you what this looks like, if we're plotting a BMI, we've got a 14-year-old boy. We calculate based on his weight divided by his height twice. BMI is 22.1 kilograms per meter squared. This is how we would plot it on a growth chart. 15-month-old girl, we find 9.3 centimeters on this x-axis and 75.8 centimeters on the y-axis to determine that this girl is 10th to 25th percentile weight for length, which tells how she's growing proportionately, which is actually really the best indicator, proportionality of growth. We care about weight separately, we care about length separately, but proportionality, if you have a child that's tall but very low in weight, we have a nutrition problem. Some limitations with BMI, particularly in the realm of kidney diseases. Our children tend to be short, and BMI may be underestimated. We may make these children underweight artificially using their height because they have delayed maturation. I'll show you how to do height age on the next slide, but we should not be using height age once a child has reached their final adult height because they're done growing. Children with kidney disease have high fat and low lean mass, as well as a high level of central adiposity. So BMI may not reflect true adiposity. And unfortunately, our patient's muscle level does decline, which we can try to combat, but it is a reality of chronic kidney disease. So waist for height ratio, which I'll show you in a minute, may be a way to more accurately assess true adiposity. So I wanted to show you how to do height age really quick. This is a 14-year-old boy who is less than the 5th or 3rd percentile for his height. So if we want to determine what his height age is, we back it up and see where his height would be at the 50th percentile. And to determine that his height age is 12 years and 3 months. So then what we do is we calculate his BMI, which is 17, and we can plot it at the current age to see where he'd be, but then we plot it also at his height age, and we can see he's at much less nutritional risk when we're using height age. Now, weights to height ratio is a tool that's recently come out. It was done in a huge cohort of North American patients. It's pretty new, so we really need more use of it practically in all areas across the world, and more studies done on individual patient populations. But it may be a way to look at true adiposity better. So we can see we have this girl, 13-year-old, her BMI is just less than the 85th percentile, which means she is within normal limits. However, if we look at her height and then her waist circumference, she, when we divide that out, is above that 0.49. So she does have a risk for obesity and the comorbidities that come with it. This is really indicative of cardiovascular risk. Subjective Global Nutrition Assessment is one of the validated tools under the umbrella of physical exam that we may consider in assessing our patients more visually, and I've included the abstract and more information. This is a general pediatric tool, but interestingly, the primary author was a pediatric renal dietitian. So I've noted the things that may be assessed or affected by chronic kidney disease. For example, linear growth is a marker of malnutrition, poor linear growth gain, but there may be independent renal reasons why this is altered. This is why we have to look at this as a whole picture. And you can see the different criteria that can be used in creating this score. Again, this is a whole separate webinar, so I'm not going to go into details, but I wanted you to have the reference available if you want to know more. Just to go into this a little bit, I've highlighted some things that you can look at. These are all part of that score. Again, edema can be affected by chronic kidney disease. Nutrition-focused physical exam is the umbrella term for dietetics-related physical assessment, and SGNA is just one of the tools out there, but it's the one that's been looked most at in pediatric renal. Unfortunately, this slide has an inaccuracy. Those plots are supposed to be adjusted down. I think that there was perhaps something that happened to it in copying. But ideal body weight is one of those tools that we can use for determining. It's just another tool that shows us the true patient picture. So, for example, we have a child that is 10 years, and his BMI is 24.9, so actually that should be down a little bit from that plot. So this child is overweight. To determine ideal body weight, we want to figure out what an ideal BMI would be for him if he were at a normal weight. So basically, we work the BMI calculation backwards. We take that BMI that he would ideally be at, take it times the height again, and that actually gives us what the child's ideal body weight is. And then if we want to further assess, we can take that percent ideal body weight and divide the actual weight by that ideal body weight to determine that this child is 145% of their ideal body weight. And again, this is very similar to SDS or Z-scores, but it is just another tool that helps us visually describe how overweight or underweight a child is. Again, physical assessment guidelines, I don't have time to go into this specifically, but this was actually adapted from a presentation that a dietitian trained in physical assessment gave us, but some of the parameters that you can look at to determine fluid overload or dehydration, fat stores, and lean mass when you're assessing your patients. Okay, so very briefly, we're going to talk about managing overweight and obesity. As I mentioned, 40% of those in the Middle East are overweight or obese. Since this is very similar to the US, I'm doing some pulling of data from the US. We know in the US that we have big numbers of overweight and obese. And so our numbers in peds renal are very similar to our US population. We also know that children with glomerular disease that may be treated with steroids, overweight is even more common. Now, we have a dilemma because if we have these patients just not stop eating and losing weight quickly, we slow their metabolism, we create issues with muscle wasting. So first of all, we want to consider linear growth. So a child who maybe could benefit from growth hormone. If interestingly, a lot of these kids have weights that are about the 50th percentile, is that they're very short and thus their BMI is elevated. However, if they truly do need to lose weight, we want a slow weight loss, no more than about a pound a week. Exercise to try and maintain that muscle mass is the primary means. And certainly determining their underlying issues, whether it's depression from their disease state, and they turn to food for comfort. There's a whole host of reasons psychologically that we need to straighten out to promote healthy weight loss. I just wanted to show you what this looked like. This is a former patient. You can see, even though they were fairly proportional here, their length trailed off over time, and so did their weight. The big clue was head circumference. This child had a normal head circumference originally, and it trailed off. That was our biggest clue this child was malnourished. And when he was admitted to the hospital and given regular feeds, both his weight and length started taking off. So just I wanted to exemplify that sometimes why we need multiple pieces of the puzzle. You'll notice that this child was adjusted for 32 weeks gestation. This growth chart was pushed back 2 months, which I'll explain in just a moment. This is a child who you can see at diagnosis, they had a rare kidney disease. They were failure to thrive here when they were diagnosed, but once we had a diagnosis and appropriate treatment, that weight for length improved, head circumference improved, all growth parameters improved. I just wanted to show some challenges with obesity. You'll notice here this child is actually at the 50th percentile, but because growth was not adequately addressed, the child didn't get on growth hormone, which this curve here is that child getting on growth hormone. She ended up obese. This is actually when we got psychology involved, and the psychologists actually worked with the parents to set appropriate boundaries. They felt sorry for their child that she had chronic kidney disease, and they were letting her basically eat whatever. And once they set boundaries and did appropriate meals and snacks, the weight loss was able to happen. Putting the tools together, a couple more things that can be useful. Our youngest children that are most vulnerable, we can kind of micromanage their weight and watch it a little more closely. Certainly not day by day, but a week or a month's worth of data will show us if they're growing at an appropriate number of grams per day. And if these are based on the WHO growth charts, so they are appropriate worldwide. And so if our children are falling out of these parameters, we need to adjust their nutritional intake or other parameters. Prematurity, This is based on British data, but children who are born between 32 and 36 weeks, we can consider adjusting their growth chart back the amount they were premature to give us a clear picture. Because if all our plots are well below the 3rd percentile, that's hard to visualize. So if we adjust it, we can get a better picture of how they're actually growing. I am a big fan of plotting their actual age concurrently so we can see if they're making catch-up growth, because by the time they're 1 in children born 32 weeks or later, they should be caught up by age 2. That's true if they were born 32 weeks or sooner. Some other potential indices that can be used, but there isn't as much evidence for: mid-upper arm circumference. There's some emerging evidence in pediatric renal, strong evidence in general peds that this can be a marker of overweight or malnutrition. Hand grip strength, there's one study, so it's not really a valid tool yet. We really need more data on that. Bioimpedance analysis is used to look at body composition, and especially euvolemic weight. A lot of centers in Europe will use this, but there's not enough evidence to validate it yet, and it should be used by a trained clinician. Another big machine that you can use that's pretty accurate, but of course that machine costs money, and there's only one small study in peds renal. A lot of centers have created their own tools, but these are not internationally validated, and a couple others that are not considered appropriate that you may see in the literature. Of course, we have to remember to keep this in the context of dietary intake, as well as biochemical measures. Certainly, if a child is eating well, that might be true weight gain, as opposed to if they're not eating well. Having patients take pictures of their food before and after they eat a meal or snack and emailing it to a clinician can be a great, more accurate visual tool that's really hot in the literature right now. And a 3-day food record is optimal, but that may not be realistic for busy families, low literacy families. So asking about 3 separate days as a recall is a tool. We don't have a lot of great biochemical parameters. PCR is the only one validated in pediatric renal, but looking at BUN trends, like if a patient has no urine output, we expect that BUN to be higher than a healthy patient, and if that BUN is dropping off, that can be an indicator. We talked about albumin or sodium. Potassium is released into the body when there's tissue breakdown, so muscle breakdown. A low prealbumin, prealbumin is artificially high in kidney disease. So if you have a low level, that's really a low level. Low cholesterol has been validated in adults, but not peds yet. These are all some things that in the bigger picture of anthropometrics may be helpful. This is just a summary slide in interest of having time for a couple questions. I'm not going to go over it, but just hopefully a summary of what we've talked about today. So at this time, I'm happy to answer any questions. I apologize that I didn't leave much time for questions, but I'm happy to be available to answer questions as long as needed.
Thank you, Chris. That was great for taking us through that topic in so much detail. We do have a couple of questions that have been submitted, so thank you for taking the time additional to answer them. The first one is, can you tell us a little bit more about using the waist to height ratio in this patient group? Is it used commonly at this point?
Great question. So this is a brand new tool. The CKID study, which has nearly 1,000 patients, looked at this tool and found it to be a very valid measure of adiposity and consequent cardiovascular risk. There's been another study in transplant patients, a smaller group at a single center, that showed the same thing. I think this is a great tool, and it's going to be emerging as a great way to truly assess adiposity, since we know that there are limitations with BMI. I think we just need to see this in practice more often. And why I wanted to share it with everyone today is because I think it is a great additional tool that's going to be up and coming.
Great, thank you very much. And another question we have here, in your experience or in your preference, would you do most of these anthropometry measurements yourself at a clinic, or would it be other healthcare professionals, like healthcare assistants or other members of the team that would take the measurements?
Another great question. So the important thing is consistency. I was fortunate to work in a clinic where we had a nurse that did almost all the anthropometrics. Obviously, she, could be sick or be off, but we had a couple nurses that were trained to do these and pretty consistently did them. Just because my dietitian time was busy, I couldn't do anthropometrics on everyone. But the point is, you need somebody trained to do these measurements accurately. And often a parent can help, like with a length, keeping the upper body still. However, if you're concerned about the training of your nurses or other staff, first of all, it's appropriate to train a few people to do these consistently, but the dietitians certainly can do these themselves. I will mention when I did surrogate measurements like arm span, I did do those myself, actually with a second dietitian, so that we had a second pair of eyes. I didn't expect the nursing staff to be trained in doing those regularly, and since we didn't do them very often, I just, for consistency's sake, always did them.
Great, thank you for that answer. And we have one more question here that's come in. Would you be able to just talk through how to calculate the ideal body weight from BMI, that backwards calculation again?
Sorry about that. There was so much information that I wanted to share with you guys today, so that you had really all the tools at your availability. I know I went through some of them quickly, but I tried to include calculations and visuals so that you can refer to these handouts later. But basically, we know that BMI is calculated by taking the weight in kilograms divided by the height in meters divided by the height in meters again. How we determine ideal body weight is we go on the growth chart and we figure out where the 50th percentile is for that age. If we have a 7-year 3-month-old, we're going to go down to what the 50th percentile would be for an average male 7-year-old 3-month child. And whatever that BMI is, that's our ideal BMI. So we take that ideal BMI because we work backwards. We take it times their height in meters, times their height in meters again, to determine what the ideal weight would be. And that's how we determine ideal body weight, is we work that calculation backwards, because we already have the BMI and the height doesn't change. So we take that times height in meters times height in meters to determine what that ideal body weight is. I hope that explained it more thoroughly, and hopefully the calculations in your handout you can refer to and have that as an example.
Great, thank you very much for that, Chris. I have one final question. It's actually something I thought of myself. You mentioned that some of the growth charts for older children have charts for head circumference as well. Is that something that's often measured in older children, or is it particular to chronic kidney disease or anything?
Actually, no. And the reason I highlighted it was I was surprised that those SOTI growth charts had head circumference, because to my awareness, certainly the WHO and CDC growth charts don't look at head circumference in children older than 3. And as far as I know, other parts of the world do not include head circumference. So I just thought it was interesting that they included head circumference in older ages. Now, your head does keep growing past age 3, but most of the growth and really what's critical for neurocognition is established by age 3. So I'm guessing that these SOTI growth charts just wanted to extrapolate that out, because the head does continue to grow, but it's really most important in under age 3. So actually, I just highlighted that as kind of an oddity, but certainly I don't think you would need to look at head circumference after the age of 3, but if they want to, that's totally fine.
Okay, thank you. Good to know. I think that was our final question. So I'd like to thank you, Chris, for presenting today. We hope that the presentation has been informative and helped advance all the attendees' knowledge in this area. This concludes today's webinar. And on behalf of Vitaflo, we would like to thank you all for tuning in today. Please take the time to complete the evaluation questions before you leave the session. So goodbye and enjoy the rest of your day.
Thank you for your time, everyone.